So in this session we're going to look at apoptosis and how we can induce apoptosis using targeted pro-apoptotic anti-tumour agents. We're going to look at a quick reminder of apoptosis, because we've covered that in a previous session, and then look at drugs that specifically activate receptors or activate proteins that will specifically drive apoptosis in cancer cells. So apoptosis is initiated by DNA damage. Any sorts of cell stress can induce apoptosis. Immune cells certainly can, and immune cells in part initiate apoptosis by activation of death receptors using cytotoxic membrane-bound ligands, things like TRAIL, Fas ligand, and we're going to cover how that pathway is normally regulated and how it can be activated pharmacologically. So the main ligands that we're interested in that drive death receptor mediated apoptosis are tumor necrosis factor, which binds the TNF receptor, Fas ligand binds Fas, TRAIL, which is the TNF related apoptosis inducing ligand, binds to death receptors 4 and 5, known as TRAIL receptor 1 and TRAIL receptor 2. So TRAIL is a normal transmembrane protein. You find it on the surface of certain immune cells, particularly NK cells, natural killer cells, and they can induce an anti-tumour response directly. We find that some tumours will undergo apoptosis in response to recombinant human TRAIL, and this is a soluble version of the normal membrane-bound ligand that we find on immune cells. So clinical trials have been underway for quite a few years to test this as an anti-cancer strategy, because non-transformed normal cells tend to be unaffected. So this diagram shows how TRAIL binds. It can bind to either death receptor 4 and 5, which is TRAIL receptor 1 and 2, or it can bind to these decoy receptors, decoy receptor 1 and decoy receptor 2. The most straightforward signaling pathway for apoptosis is TRAIL binds death receptor. That results in activation, well, initially recruitment of procaspase 8 to this, which is what we call the death-inducing signaling complex, where we trimerize the death receptors. We bring in 3 FAD proteins. That recruits procaspase 8. Procaspase 8 sort of self-activates, produces active caspase 8. That activates caspase 3, and that induces apoptosis. So type 1 apoptosis seems to occur particularly in hematological cells, which are being naturally killed off very, very quickly. However, in most cells, and certainly most tumour cells, type 2 apoptosis occurs, where we get TRAIL binding to the death receptor. It could be Fas ligand or TNF alpha, activates caspase 8, and rather than directly activating caspase 3, which can happen to some extent, it requires an amplification of this process. So caspase 8 will cleave BID to truncated BID, and truncated BID will oppose the activity of BCL2 or BCLXL. BCL2, BCLXL are preventing the activity in particular of BAX, and BAX creates pores in the mitochondrial membrane. The net result of that is release of cytochrome C, also release of procaspase 9. Cytochrome C, procaspase 9 and a cytoplasmic protein called APAF1 come together and form the apoptosome, which is effectively active caspase 9. Active caspase 9 then can cleave and activate caspase 3, then caspase 3 can help to initiate apoptosis. And normally caspase 9 can be inactivated by XIAP, X-linked inhibitor of apoptosis, and upon release of SMAC diablo from the mitochondrial membrane along with cytochrome C, XIAP can be inhibited to make sure that caspase 9, when it becomes activated, is fully active. So this additional loop here seems necessary for TRAIL signaling to get through to active caspase 3. This arrow from active caspase 8 to active caspase 3 seems a very weak arrow in normal and tumour cells, and this convoluted pathway is required. So as I mentioned, TRAIL binds to the death receptors, activates death receptors. That results in procaspase 8 activation, eventually leading to apoptosis via that convoluted route that we've just seen before, which means that recombinant human TRAIL and also death receptor 4 and 5 agonistic antibodies are in clinical trials, and some have been approved for use as anti-cancer therapies by directly activating the death receptors to drive apoptosis. Now these don't always work, and there are various pathways involved in negatively regulating pro-apoptotic signalling. One of the main ones is C-flip. So C-flip here can prevent procaspase 8 from being recruited to the death-inducing signalling complex. So high expression of C-flip can prevent caspase 8 activation. So it's thought that in some cases the cells are not responding to trail because they express high levels of C-flip. So certainly phase 1 trials of recombinant human trail have proven safe, but there's limited anti-tumour activity, and we'll go through other mechanisms of insensitivity to this trail fairly shortly. Further studies of death receptor agonist antibodies, so mimetics is one example of an anti-DR4 antibody, also demonstrate limited anti-tumour activity, and we find that tumours are either intrinsically resistant or you get rapid tumour death and then rapid resistant disease emerging. So the tumours seem to be either altering gene expression or acquiring mutations that make them effectively resistant to death receptor mediated apoptosis. However, combination therapy with chemotherapy or experimental anti-tumour agents seem to show more promising results. So monotherapy is certainly not very effective, but combination therapy might be useful. So there are lots of different ways why recombinant human trail might not work as a single agent. As I briefly mentioned earlier, trail can either bind to the death receptor 4 and 5 and signal apoptosis. It can bind to decoy receptor 1 or decoy receptor 2, and these two can mix in with DR4, DR5 and prevent trail signalling, because you require a trimer of trail to link together 3 death receptors. If one of these sneaks in there, bound to trail, that will prevent apoptotic signalling. There's also some controversial data on osteoprotegerine, which is a soluble decoy receptor for trail. So it's thought that some cells can secrete osteoprotegerine, and that can cause a local attenuation of trail responses. So this just shows the way that trail receptor agonists are in use. Now if you think that most antibodies are effectively, they bind to receptors and block receptors, so block ligand binding. These are very different. These are acting as ligands themselves. So death receptors are trimeric. The antibodies seem to help bring together multiple death receptors in close proximity, so act as a cross-linking. And so if an anti-DR4 antibody binds to one DR4, the other antigen binding region of this antibody can bring together another DR4, and there are some versions of these antibodies which are multivalent to bring together whole clusters of death receptors in close proximity. So the idea is mapimumab and these DR5 agonist antibodies can act effectively as ligands to help cluster the death receptors in close proximity and cause activation, very unlike most other biopharmaceuticals which act as antagonists of receptors. So as I said, recombinant human trail is certainly not spectacular, and this is from a clinical trial using recombinant human trail. It's shown to be safe. What we can see here is a placebo group plus, so it's a placebo group without trail, and then we've got the group with trail. But it's not just no treatment, it's shown as placebo, NP, which in this case is a vinca alkaloid and cisplatin. So these patients here have got the vinca alkaloid plus cisplatin. These have got vinca alkaloid, cisplatin and trail. And we can see we've got progression-free survival benefit by including the trail. However, that didn't result in an overall survival. And this is an example of mapimumab, an anti-DR4 agonist. Phase 1 trials show it's perfectly safe, but monotherapy doesn't work, and some of the experimental drug combinations, in this case combining it with a tyrosine kinase inhibitor, we know that certain growth factors can signal survival signals. So the rationale being, if you block the growth factor signals and put in a pro-apoptotic signal, you may get some synergy going on. However, there was really no difference between these two groups. So this is a problem that we're seeing with this class of drugs, is sometimes they just don't have any activity. So to try to find out how we can exploit this pathway, a lot of work has been done in recent years to look at how trail receptor signaling can be enhanced by other anti-tumour agents. So lots of work has gone into classic chemotherapy, so doxorubicin, 5-fluorouracil. Combine these with trail, you stress the cells, you then hit them with trail or death receptor agonists, and that can drive further apoptosis. So combination of DNA damaging agents seem to enhance trail responses, so does irradiation. But then we can get on some other non-cytotoxic methods. So proteasome inhibitors, they were one of the first main trail sensitizing drugs. They very efficiently enhance trail responses. Histone deacetylase inhibitors, including some of my own work, has shown that HDAC inhibitors can really potently enhance trail responses in multiple myeloma. Up here we've got some other agents, small molecule BCL2 inhibitors. I'll get onto these later. They are also shown to be trail sensitizers. XIAP antagonists, which we saw XIAP earlier, they also enhance trail responses, and they're not shown on here, which is a new class of trail sensitizer from my own group's work, is that nuclear export inhibitors such as leptomycin can also enhance trail responses. So this is some of my own group's work showing that histone deacetylase inhibitors, we'll come across those in a later lecture in this series, but HDAC inhibitors tend to result in re-expression of silenced tumour suppressor genes. The rationale being that for using these in combination with trailers, there may be some silenced tumour suppressor genes, maybe like BAX or something else, that's been silenced epigenetically. If we can cause them to be re-expressed, combined with trail, we may get a more potent tumour kill. And what we can see here is that this is 3D cell culture of multiple myeloma. Treat with trail, we get a bit of death. Treat with SAHA, we get a bit of death, and these very bright cells are apoptotic cells. Combine trail and SAHA, which is a HDAC inhibitor, and we get the majority of cells killed. We can then block that activity with caspase 3 inhibitor, showing that this is an apoptotic mediated response. Okay, and here's another study, another recent study from my group, showing that nuclear export inhibitors, which is this fairly new class of anti-tumour agent, how they work is they trap proteins in the nucleus that would normally be exported, and one of those key proteins that's trapped in the nucleus is likely to be p53. That gets exported when it's no longer needed. The nuclear export inhibitors may well be trapping p53 in the nucleus. That stresses the cells. We then hit the cells with trail and we get more death. So these are cells staying with Hirsch and propidium iodide. Those are apoptotic cells. Treat with trail, we get a little bit of death in these osteosarcoma cells. Treat with leptomycin, which is the nuclear export inhibitor. That has very little effect. So there's your control, there's your trail, there is your leptomycin B, and then there is a combined treatment. And what we can see here is the combined treatment is greater than additive of these two together. And when we start pushing up the dose of leptomycin, leptomycin does very little on its own, trail does very little on its own. You combine them together and you get a synergistic enhancement of death receptor mediated apoptosis. So there are various different mechanisms that are well characterized that suggest why trail receptor agonists might not work very well. We know that some cells can downregulate the cell surface receptors by internalization. We know that altered glycosylation status and downregulating this gene can result in altered trail receptor glycosylation. We know that tumour cells can increase C-flip. C-flip can prevent caspase 8 activation. They can overexpress the cellular inhibitor of apoptosis 1, which is a direct caspase inhibitor, or causes caspase degradation. And we know that specific mutations of AKT or P10 deletions can drive trail resistance. So specific mutations here or here can make cells trail resistant. So this is shown here. This paper by Nesterov from many years ago showed that elevated AKT activity can protect prostate cancer cells from undergoing trail-induced apoptosis. So these cells are often P10 deficient, and if you have cells that are deficient in P10, you get constitutive AKT activation, and that can drive cell survival, and we'll see why on the next slide. But this also links in closely with growth factor, and particularly tyrosine kinase receptor signaling. If you get growth factor signaling, you drive this pathway more strongly, which can drive cell survival and apoptosis inhibition. So withdrawal of growth factors can make cells trail sensitive. Strong growth factor signaling can make them more trail resistant. So this slide shows how activated AKT can cause cell survival, and this is primarily through BAD. And BAD is one of these pro-apoptotic proteins that will bind to, in this case, BCL-XL, and prevent BAX from being able to cause pores in the mitochondrial membrane. So if AKT is activated, BAD is phosphorylated, and that allows BAD to be sequestered away from the mitochondrion. Whereas if AKT is not active, BAD can then bind in with BCL-XL and prime the mitochondria for a pro-apoptotic response, and in particular allowing BAX to come along. If BCL-XL has been bound to BAD and effectively mopped up, then BAX can punch holes in the mitochondrial membrane, releasing cytochrome C, activating caspase 9, and then we get our apoptotic cascade occurring. So ACT activation will prevent BAD from binding to BCL-XL. So BAD is here. BAD is one of these BH3 BH3 only proteins, and we have a group of drugs called BH3 mimetics, which effectively do the same job as BAD and some of the other related BH3 only proteins like Puma, Noxa, BIM, and BID. We came across BID earlier because BID is cleaved to TBID by caspase 8, and that primed a cell for apoptosis. So you've got your pro-apoptotic proteins. Let's focus on BAX because that's the main one. And we've got the pro-survival proteins, and let's focus on BCL2. There's also BCL-XL. And BAX can punch holes in the mitochondrial membrane, but only if it exceeds the level of BCL2 on the mitochondrial membrane. So BCL2 acts to mop up BAX, but if BAX exceeds BCL2, BAX can punch holes in the mitochondrial membrane. The BH3 only proteins are present to bind to BCL2 to prevent it from binding to BAX. So if you can have lots of truncated BID, lots of BAD, then you can get away with apoptosis occurring with less BAX being present. So the BH3 only proteins, such as BAD that we saw on the previous slide, prime the cell for apoptosis, and then BAX can then actually do the job of creating holes in the mitochondrial membrane. So there are a whole range of related proteins here. We've got BCL2, BCL-XL, and a whole range of other BCL2-like proteins which are anti-apoptotic, which will bind to either BAX or BAC in this case. But then we've got these BH3 only proteins, BAD, BIM, Puma, BID, and Noxa, which can effectively mop up and sequester BCL2 related family on their on the mitochondrial membrane, allowing BAX to do their job. So the job of the BH3 only proteins is in response to stress. They are expressed and they bind to the BCL2 like proteins or BCL2 itself. So the nicest example is Puma, which is a p53 upregulated modulator of apoptosis. So in response to p53 being expressed, we know that p53 induces BAX. Well, p53 also induces Puma. Puma can come along and bind to BCL2, effectively sequester that BCL2 or prevent it from binding to BAX, and that allows the BAX that is produced to create the holes in the mitochondrial membrane. So without Puma binding to BCL2, you would require more BAX to create those holes in the membrane. So this has been exploited pharmacologically by producing some small molecule inhibitors that bind to BCL2, so the Navitoclax and Venetoclax, they both bind in a to the BH3 only protein binding domain, so they bind to BCL2 in exactly the same way that Puma binds to BCL2. So you can give venetoclax, and that's just like having lots of Puma in the cell, so that can prevent BCL2 from inactivating BAC or BAX. So therefore, even if you get a moderately weak BAX induction by giving venetoclax, that BAX will be available to create the holes in the mitochondrial membrane and induce apoptosis. So these are pro-apoptotic. So although these do have activity, as always, there's going to be some sort of resistance mechanism present. And what we find is if we treat cells or treat patients with venetoclax, venetoclax will render the BCL2 binding site inactive. So what tends to happen is by treating with venetoclax long term, you get mutations such as this glycine to valine mutation in the BCL2, causes a change from glycine 101 to valine 101 in BCL2 protein. This prevents venetoclax from binding, and therefore these cells are resistant to that mechanism. So in summary, death receptor agonists induce apoptosis by activating the death receptor. This creates a death-inducing signaling complex and results in initially caspase 8 activation. Typically caspase 8 will either activate caspase 3 directly in type 1 cells, or in type 2 cells cleave BID to TBID. TBID will act as one of these BH3 only proteins and prime the mitochondrion for BAX induction of apoptosis. We can give trail or death receptor 4 or 5 agonists. They all have very good safety profiles, but monotherapy is really poor. Combination therapy is variable. Some novel or some newer trail sensitizers are looking a little bit more promising, but in general there are loads of different ways in which trail signaling can be inhibited by the cell, and only one of these is required to stop apoptosis induction. The sort of resistance that we get is overexpression of C-flip. We can get constitutive activation of AKT or PI3 kinase, or we can get deletion of P10, and this will result in sequestration of BAD, which will be pro-survival. We can then look at the BH3 only proteins. These prime the cell for apoptosis by blocking the BAX and BAC binding sites on BCL2 itself. So BH3 mimetics bind to this same site. They bind to BCL2, they prevent BCL2 from binding to BAX or BAC, and therefore whatever BAC or BAX is lying around, that is free to then create the pores in the mitochondrial membrane to release cytochrome C and procaspase 9. These drugs do show activity, particularly the BH3 mimetics. However, you do get secondary mutations to the BCL2 gene that result in venetoclax from not binding, and that seems to be the primary resistance mechanism for these drugs.